Okay, so looking at CT, we're going to just go through some of the basics. So, based on the principle that density of tissue can be measured based on how easily it can be penetrated by an X-ray beam. So the tube and the detector rotates around the patient whilst the patient moves through the bore. So what are you looking at? You're looking at an axial view, looking up from the patient's toes, and it's reconstructed into the coronal and the sagittal planes. Within MSK, you can see bone in much better detail. So you're able to see the trabecular pattern and the cortical breaks. Wherever we depict HU, that depicts the Hounsfield scale, which was named after Sir Godfrey Hounsfield and is a quantitative scale for describing radiodensity. So if we look at some of the radiodensity, so pure water has a radiodensity of 0, fat minus 70, air minus 1000, CSF plus 800, and so on, and bone and calcification of plus 1000. So looking at the Hounsfield units of the skull here, you can see that the bone shows up really nice and bright white. The white matter has a lower Hounsfield score of between 20 to 30, so shows up quite dark. CSF shows up really dark because it has a Hounsfield unit score of 0. And then air minus 1000 shows up dark around the outside. So within CT, you can obviously do a CT scan if you have a metal artifact, but it will cause a hardening artifact through the image that you have. So the beam hardening caused by dense objects, and it causes streaking through the image that you have. And then you also get issues with movement artifacts if the patient is moving around, if they're in pain, or they're not very good at sitting still. You'll end up with movement artifact. Metallic artifact will give you this distraction. So you can see you've got these lines coming from the central aspect of the metal. And then you've got an artifact caused by high concentration of iodinated contrast. So this is where the iodine contrast has been taken up in much greater quantities here. So you've got this artifact here. Show the 3 different types of CT scan, and you can see here that you can reconstruct the pelvis and the bony anatomy really quite nicely in 3D. So this is really useful in trauma imaging to be able to recreate a 3D image. Dual energy and spectral CT uses 2 separate X-ray energy levels and can be used to detect bone marrow edema and can be used to detect and quantify uric crystals as well in gout. So you can see here, you can see the build-up shown in green, and you can see that here. Looking at it in plain film, you can't see that there's a differentiation, but the CT shows quite nicely. So this would be normal. Again, normal views. Looking at this case study, so a patient with right ankle and foot crushed by a 3-ton digger, X-ray confirmed bimalleolar and calcaneal fractures. So what they're trying to do with the CT is plan the extent of the injury and what they're going to do pre-op. So you can see here you've got a calcaneal fracture, malleolar fracture here, calcaneal fracture, malleolar fracture there. Pre-op here, you can see here. So the X-ray didn't pick up the avulsion fracture of the fibular attachment of the anterior talar fibular ligament. So the CT itself has picked this up in a lot more detail here. Patient here complaining of injury and pain and swelling. So you can see there. X-rays well defined, expansile lucent lesion. So they queried a pathological fracture. That's there. Then conducting a CT scan has shown destruction of the cortex and trabecular pattern, and querying an endochondroma, just there. So patient with prostate cancer and pain, querying METs, so soft tissue with bony METs, sclerotic METs, and acetabular fracture risk. So thinking about the quality of the bone here, you can see it's cystic, and into up here you can see the quality of the bone here. It doesn't look right. These would be your metastases of the bone. So patient fallen to outstretched hand 8 weeks ago, still complaining of pain. On the X-ray, showing some issue here, non-united fracture. On the CT scan, showing that there is some union on the dorsal aspect, on the opposite aspect, non-union there, which would be the reason for the pain. Looking at the patient's foot, looking at some partial union here. This would be on the X-ray, and then looking at it from a CT perspective, you can see there is no union here. It goes all the way through and translates all the way through, as you can see there. Periprosthetic fracture of the hip, pre-op. So we're looking, obviously they've had a replacement here, and then they've got this fracture straight through there on X-ray. Looking from a CT point of view, really difficult because of the metal artifact. You're then unable to see in greater detail what you're trying to look for because of that artifact. So in this case, CT would not be indicated. Looking here at the elbow, OA for surgery. Looking here, just looks pretty cruddy, rubbish bone quality, and again, you're not really seeing too much because it's just all overlying. And then if you look on scan, you can see cortical bone fragments on the volar surface. You can see severe OA and marginal osteophytosis as well, so lots and lots of spurs within that joint. And then if you rebuild the joint using the Clever 3D aspect, you can see exactly how rubbish and arthritic that joint is itself. So you can recreate it. You can see all those bony spurs around here. So here we're looking at sternoclavicular dislocation. On X-ray, can't really see too much around the area because there's lots of overlying structures. Looking on CT, you can see the sternum here. You can see the clavicle in joint, clavicle out of joint here. X-ray, you can see you've got dislocated shoulder. So clinically, you know you've got a dislocated shoulder. If you want to know what you're going to do in relation to that, is it a recurrent dislocation? Is it a traumatic dislocation? Looking on CT scan, you can see the glenoid itself is flat. So that's never going to hold that shoulder in place. It's going to be a chronically unstable shoulder. So that would be for surgical procedure, potentially Latarjet procedure. This patient had a fall, diagnosed on X-ray, no fracture, but patient's unable to mobilise and unable to weight bear. So looking from a CT perspective, you can see they've got an intertrochanteric fracture here. So going forwards, if you look a little bit further, you're looking here at intertrochanteric fracture. Intertrochanteric fracture there, look. So here you're looking at a T12 and an L2 fracture. So you can see the destruction of L2 here and the destruction of T12 just here. Looking at it from this perspective in terms of weight bearing, you can't see anything effectively, particularly. If you look at it from a transverse point of view, you can see from the T12, which is this one here, that it's indented into the spinal canal itself. On the L2, you can see that you've got this pretty rubbish bone density, indicating an osteoporotic L2. So based on the images from the CT, it might just be worth making some notes about what you'd expect to find on the more common aspects of MSK-CT that you would be asked to look at, or maybe have a look at depending on your area of work. So have a think about spinal CT, have a think about talar dome, shoulders, knees, and also potentially elbow if you're working within an upper limb setting.